Hi, I'm Lieutenant Commander Chad Moore here with Commander Ray Bonds. We are staff nurse anesthetists at Naval Hospital Jacksonville, also assistant professors of the USU Nurse Anesthesia Program. And we're here to talk to you about skill retention for our tech. Here are our objectives. We'll describe the features within existing systems that enhance skill retention and do a little mention of what doesn't seem to work here and there. We will provide recommendations on how to design simulators to optimize skill retention. So, like I mentioned before, our field is anesthesia. Although we are nurse anesthetists and not physician anesthetists or anesthesiologists, the skills we are expected to maintain in the operating room are exactly the same. Here's an example of how anesthetists are certified in the UK, and don't worry, we'll get to the US in just a minute. In the UK, anesthetists initially get certified by the Royal College of Anaesthetists by taking a written test, an oral test, and then a skills exam. The skills exam is 18 parts, 16 of which are graded as pass-fail, and one or more can be on a high-fidelity simulator. These skills do appear to be independent of one another as they are each limited to about 5 minutes, so given that it is only 5 minutes each, they should be relatively simple. Of course, we're not privy to a more detailed examination description that would be available to the general public because it's kept under lock and key. Interestingly, they are not using a simulation to test for skill retention, as they've omitted that part of the exam from the repeat exam. But it lets us know what the expectations are for assessing skill retention. Now, in the United States, we have the National Council for Certification and Recertification of Certified Registered Nurse Anesthetists, NBCRNA for short, because that's a mouthful, and the American Board of Anesthesiology, ABA, that govern and if and how skill retention will be measured at the certifying body level. The NBCRNA does not have a simulation requirement at this time, just a continuing education and a written test in a 2-part 4 to 8 year cycle. And here we'll show what the ABA has been doing. Now, the ABA developed a Maintenance of Certification in Anesthesia program that they call MOCA, slightly different than the Starbucks version, which is a 2-part 5 to 10 year recertification cycle. In addition to the written test, they also had what they called Part 4, which included a simulation every 10 years. They abandoned this technique, this simulation, and the infrequent testing. The test is now smaller, offered once a quarter, under much less formal conditions, and it's focused on learning, using the adult learning principles that tell us when a person answers incorrectly, it helps them learn for future practice, which supports more frequent testing as well. They're repeating the substance of the questions that were missed at certain intervals to improve the learning. What I found interesting is that even though it used to be required and is no longer required, it is still valued, with 3 times the credit per hour of the other options for recertification, but at substantial cost of $1,500 for a 6-hour course. Now, why would we use simulation-based assessments? We want to enhance the skill acquisition and retention compared to just training. The testing itself, going through that process, does enhance the retention of the student. Test preparation enhances the learner's motivation to study in the first place. So they actually went through and they found out that the people who were getting ready to go for these simulations, they answered questionnaires and they said, yes, I did prepare a little bit before because I knew that I was going to be in front of my peers. These tests needed to be spaced over time. The objective structured clinical examinations, OSCEs, are limited for formative learning outside the classroom because they're extremely expensive and they're not often enough for formative learning, more of a summative learning, which doesn't really help when you're trying to take care of patients better over time. Performance assessments using assessment measuring skills required in healthcare, they do elevate the practice standards. So we know exactly that everyone is practicing at the same skill level. So we know what the standard is. And through that we improve patient safety because everyone is practicing that standard. For the ABA, as I mentioned previously briefly, MOCA, Maintenance of Certification Anesthesia, the traditional way, was offered in the Part 4 requirements as a summative test. It was abandoned, but now it's still optional in MOCA version 2.0. Now it's 6 hours, $1,500, but don't worry, you get a free lunch at the Mayo Clinic. Focused on non-threatening learning. It's a 1:5 instructor ratio to student. This enables a small group, personalized learning, real-time feedback that you need to really get something out of it. Minimizing performance anxiety because it's in front of peers, and although it's not what you would expect of someone trying to perform with no anxiety without the peers, it does give you a certain level of anxiety of performance in front of peers as opposed to no anxiety at all. So a little bit of learning because they know the stakes are elevated just a little bit, but not so much as to be to cause the anxiety to go so high that you don't learn anything. And they do teach these students to keep it within that group. So if, for example, a person who's undergoing this simulation session, one of the students there, if they have a peer that's there and they observe that peer to be performing substandardly, the guidance there is that what happens in the room stays in the room and doesn't leave. So that's the kind of culture that they're teaching in that area to make it less threatening. It's not graded. The participants are able to call for help at any time, but usually that help takes a while to get there, so they're able to run through their own thought process and kind of formalize their thinking without just immediately pulling the string and hoping someone will come and save them. There is a debriefing after each case, and they offer the students to and encourage them to reflect on their performance and what they should have done or what they learned from it. So building teamwork and communication skills in the ABA simulation. We want to, through this, we're communicating the latest best practice to providers, like I said, standardizing it across the providers. We're standardizing handoffs through these things, standardized checklists for treating patients, crisis management, all based in standard guidelines based in the literature. And then they also have projects that follow up for follow-up projects for the providers. So these providers are mailed a questionnaire. They have to indicate how the session changed their practice, and they often respond with that they have created quality improvement projects of their own at their local hospital. So it's making an impact at their local institution. These evaluations, what's come out of those surveys, 95%, of course we have some bias because it's from the institution that's offering the course, but 95% recommended it to colleagues, 98% participants felt that the simulation was relevant to their own practice, 95% saying that the lessons learned from the simulation had led to changes in their own practice, and most people say that they were really engaged in getting the patient safety initiatives at the local hospitals going. And to talk about skill at the local level is Commander Bonds.
Thank you. I'm going to talk about simulation for skill retention at the local level. Simulation training is based on the adult learning theory. The difference between children and adults stems from maturity, age, and experience, all leading towards an independent and self-directed adult. Therefore, adult learners need the following to learn: the rationale for needing to learn something new and expend energy, The ability to have independence with some degree of self-directed learning, value giving for life experiences, the ability to learn things that help with everyday coping, life-centered or real-life scenarios, and internal drive or motivation. Many in the field of anesthesia equate experience with clinical competence and expertise, but this is not necessarily true. Simulation training is not just for the novice anesthesia provider. Skill decay, is defined as the decline in skill over time due to non-use. The longer the period for retention without skill use, the greater the skill decays. Without the use of deliberate practice with feedback, experienced anesthesia providers may not be optimal in the time of need. This may be particularly important for an expert anesthesia provider who traditionally receives much less feedback on anesthesia performance compared to a novice anesthesia provider. Compounding matters. It may be possible to have an expert anesthesia provider who feels intimidated by simulation training if it's not framed in a safe and learning environment. Providing an expert anesthesia provider an opportunity to simulate anesthesia scenarios that are high risk but seldom performed is more robust if it's conducted on a regular schedule and not conducted in a mass training evolution. So the first type of simulation we're going to discuss is low fidelity training. Low fidelity training typically refers to procedural training involving but not limited to intravenous arms, airway heads, and CPR mannequins. This is a neuroaxial trainer located at our local hospital. The trainer is located within the simulation department and can be utilized by an anesthesia provider 24 hours a day. At our institution, we often have reservists, sometimes anesthesiologists or nurse anesthetists who do not work in the OB environment. So for them, having access to the low fidelity neuroaxial trainer allows them to refamiliarize themselves with the steps associated with performing an epidural, spinal, or combined spinal epidural, and just as a refresher and reinforcement of their skills. The procedure steps can be attempted with a low fidelity simulator to refamiliarize the anesthesia provider with placing neuroaxial techniques as we've discussed. The same concepts can be applied to techniques such as central line placements, cricothyrotomy, and rapid catheter insertion utilizing other low fidelity training simulators. The second type of simulation is high fidelity training. High fidelity simulation scenarios involving a full body mannequin with multi-system functions could be utilized to refamiliarize anesthesia providers with high-risk, low-volume situations. Simulating the scenario with cardiac arrest manifested by absence of pulse and decompensated vital signs allows the anesthesia provider to practice emergency interventions without actually harming a patient. High fidelity refers to the degree of realness replicated during the training evolution. High fidelity simulators can replicate breath sounds, heartbeat, and anesthesia emergencies such as laryngospasm, bronchial spasm, cardiac arrest, hemodynamic compromise, and other scenarios that allow the anesthesia provider to reinforce concepts and skills learned in the past but are low volume, high risk situations. A more recent and exciting development is computer simulation, which allows the learner to maximize their time by learning when it's most convenient to them. A computer simulator allows the learner to reinforce their learning through an electronic format. The advantage of computer simulation is the low cost associated with the purchase of software for most hospital or training institutions. It is not unreasonable for an institution to pay under $1,000 for the software and just pay additional fees in the future for periodic updates. Also, having a web-based system allows the learner to access scenarios instantaneously. The only requirement is computer access and internet connection. Having multiple scenarios available for computer simulation is another advantage. These scenarios include but are not limited to cardiac care, anesthesia, critical care, neonatal, obstetric, pediatric, and sedation scenarios. The next type of simulation is immersive simulation, a powerful tool in which a planned activity takes place involving a learning group in an environment that is realistic. There is a simulation learning pyramid that effective simulation is based on and includes the simulation plan, the actual simulation scenario, the debriefing, and transference. The simulation plan is developed by the facilitators with the following included: predefined learning goals and objectives, a description of how the case will play out, including plans for appropriate responses from the simulator to the participants' actions, scripts for actors who played the voice of the simulator, family members, nursing, pre-hospital provider, consultants as the learners are guided through the simulation. This plan should include the creation of a safe environment for the participants to learn. The immersive simulation can be conducted in a clinical area in which the learner actually performs the task, in this case, the main operating room. Realism is created by adding stimuli to the physical space to include sounds associated with an operating room, patient monitors, suction machine, electrocautery, etc. The role of actors forces the learner to communicate and interact with other staff members and patients, providing another level of realism. This could be easily incorporated with having the learner obtain consent to a patient who is so critically ill he or she may actually die from the surgery. Immersive simulation allows the anesthesia provider to have real-life patient encounters after attaining a level of clinical and technical efficiency and confidence. A crucial part of the simulation process is the feedback given to the learner, the debrief. It is imperative that the learner can critically reflect on the simulation with his or her performance. The learner is guided during the simulation while learning objectives are discussed and diagnostic feedback is given on the performance. Simulation training provides an opportunity for insight into key events. The goal is for the learner to gain positive reinforcement in aspects of simulation that were done correctly, even if the overall outcome is less than optimal. The learner can utilize this knowledge to focus on areas needed to improve with direct feedback given. It is not uncommon for participants to acknowledge that they feel improvement is needed without even being prompted. So in conclusion, there are multiple avenues for recertification in anesthesia. Skill retention is an ever-changing topic in anesthesia. High fidelity and computer-based simulations stand on the forefront of today's standard.
Thank you. There.
You just ready to re-record it?